We're going to start with session one. My name's David Marin and my co-moderator, Mike McConnell. We are the Stanford gang, and we're up here with the Mount Sinai gang. And our first speaker this morning is Dr. Amir Ahmadi. And Dr. Ahmadi is at Mount Sinai. He's Director of Cardiovascular CT and MRI Research and Director of the Valve Clinic and Director of the Lipid Clinic at Mount Sinai St. Luke's Hospital. And his presentation this morning is shifting from treating the risk of disease to treating the disease. Dr. Ahmadi.
Dr. Marin, it's an absolute honor and pleasure to be here among this amazing faculty. I'm covering actually for Dr. Narullah, who couldn't be here today. So I'm sorry for the inferior replacement, but I'll try my best. As you can see the title, what I'm going to talk about is the vision of prevention in future that I think in cardiovascular disease, what I think we need to do, and I think this is shared by the audience here, is to start seeing the disease itself, which is the disease of the coronary arteries, and I'm only talking about the disease of coronary arteries, and treating it as opposed to guesstimating. So I'm going to start with a real life case. His name is not Sam, and this is not his picture, but the case is real. This is about 3 or 4 weeks ago in our CCU. So he's a 50-year-old gentleman. He's a physician. He doesn't have any past medical history. He comes with these risk factors. His LDL was 110, A1C of 5.4, no hypertension, Ascvd risk score was calculated based on the calculator at 2.6%. He plays indoor soccer every Thursday night, and he doesn't have a chest pain, and he claims to be good. How do you categorize his risk? So according to guideline, this is a low-risk guy. And does he have any need for anything else with regards to prevention of cardiovascular disease? So if I saw him and anybody else that practices guideline in the clinic, we would probably reassure him. We would say, yeah, keep on the good work, diet, exercise, Mediterranean diet, and whatnot. Yeah. So what happens is that on a Saturday morning that I'm rounding, we get a coach STEMI. He comes with a chest pain while having brunch. He rushed to the hospital. This is his ECG. You don't have to be a cardiologist to say that this is abnormal. And he goes to cath lab, and he has a proximal to middle AD, 99% occlusion, the hazy area that you see in there. And fortunately, he has a great outcome. But cases like this makes me always think that how could have this been prevented? And is this a rare event? So aside from working in CCU, I also work in a prevention clinic for the past 7 or 8 years. And when I think about coronary disease in general, I put it in a timeline as it's seen by a cardiologist. So it starts with birth, and it goes to the first prevention visit. The point of the first prevention visit for us is to basically prevent the first MI. So from a perspective of myself as a prevention doctor, I try to prevent the MI. But when I round on a CCU and I look at the person with an MI, I ask myself, why did this happen? The problem is that between these two perspectives, there's a huge disconnect that I'm going to talk about now. As people that actually end up with MI are not always the people that we have predicted them to have the problem and the disease. And I think the solution to this disconnect that we have is to rethink about pathophysiology of MI and rethink of strategy of how we can actually see our patients and what we do for them. So let's start that. From the prevention perspective, who is at risk and how we can prevent the MI? So our framework, even though we like to be very, we sound very sophisticated, is that we basically do 5 things in our clinics as it relates to prevention of MI. We either reassure people, or we ask them to lifestyle modify, or we do medical treatment, or we send them for more testing, or we send them to invasive testing for revascularization. How do we do that? The 2 gateways that we use is either risk factors for the first 3 or symptoms for the next 2. And what we are trying to do is to prevent either MI, or we prevent the symptoms, or relieve the symptoms, or improve the quality of life. How did we get here? is basically, as Dr. Harrington was mentioning, over the last 50, 60 years of science, we had amazing data that shows on a population level, for example, risk factors are important. So that lead us to focus on risk factor and risk estimate scores. We also learned that symptomatic patients are more likely to have events, and therefore we started to focusing on symptoms. For example, we have chest pain guidelines as opposed to coronary disease guidelines. There is quite a bit of focus on symptoms there. And our non-invasive testing prior to the evolution of CT scans were very much focused on detecting ischemia and obstructive lesion because they were more likely to cause events. So that was the focus on ischemia or obstructive lesion. But when you look at it from MI and go backward, you have a patient, you're like, how did this happen? Could I have predicted this? We need to start thinking about the usefulness of these criteria, the symptoms, the ischemia, or the risk factor in predicting. And you know, the question of why did this happen and could have been prevented or not. So when you think about symptoms going backward, we know that symptoms are unreliable because only 1/3 of people actually present with stable ischemic heart disease. 2/3 of people, the first presentation of their coronary disease is either death or MI. So we cannot rely a symptom as a gatekeeper. We look at risk estimate score. This is a beautiful paper done in 2018 by the Young MI Registry Group in Boston. And what they looked at is people at age of 50 or lower that presented with their first event. And there they asked the question, if I saw this person 2 days ago in my clinic with this risk profile that they presented before their MI, could I have predicted this MI? Could I have actually started them on statin? And what you can see is pretty surprising that people that are in a high risk, people that have familial hypercholesterolemia, people that have diabetes, only constitute a very small portion of the whole population of MI. And at the bottom, what you see here is that people actually that have low risk or borderline risk constitute about 70% of people who came with MI. So I took that idea, and over the last 4 years, we did this in Mount Sinai and Mount Sinai Morningside. We just presented this a few weeks ago in London in the ESC conference. So we looked at people with a type 1 MI, 65 years or younger, and we said, what if we saw these people 2 days prior to their MI? Could we have predicted this based on the two main gateways that we have to prevention, symptoms or risk factors? So from the statin indication AHA-ACC 2018 guidelines, what we found out is that 47% did not meet the requirement for being on statin or doing further testing. And from the symptom standpoint, we looked at, we took the historical basically perspective, and we asked the patient, when was the very, very first time that you had any pain? And in 62%, that wasn't more than 2 days ago, more than 48 hours. And in about 54% of the patient, it was the same day as the presentation. So you put it together, intermediate or high risk is about 53% of the patients. Low or borderline risk is about 47%. Symptoms for more than 2 days is about only 38%. Asymptomatic up until presentation, 62%. This is our gateway. We put it all together. The Venn diagram shows that 32% of your entire MI, remember, every 34 seconds we have an MI, entire first MI, 32%, 1 in 3, are people that are low risk, that we don't even give them statin, and people that are asymptomatic. So why is this happening? Are we wrong in our risk estimation? Not really. The risk estimations were fantastic at a population level. So high risk people are more likely to have event than low risk. Ischemic people are more likely to have event than non-ischemic, and symptomatic more likely than non-symptomatic. The issue is that when you scale it to a population, the population of low risk, the denominator is much bigger than the high risk. Same with ischemic, same with symptomatic and non-symptomatic. So when you scale it and when you look at the MI going backward, even though they have the low risk or non-ischemic or non-symptomatic, they have a smaller portion of the pie. Because the pie is such bigger pie, the absolute number actually becomes a substantial number. And more MI comes from the low to intermediate risk group than high risk. More MI comes from the non-ischemic group and asymptomatic group. So that's what I call the MI paradox. So what's the solution? We look at pathophysiology. Pathophysiology is that you start with a plaque, you go through progression to get to a stage of vulnerability, which I'm going to allude to in a second, and then you have a plaque rupture. So the pathophysiology is not telling anything that is lie. It starts with a plaque, it ends with a plaque rupture. It's all about plaque. So what we can actually do is to realize this disconnect and move forward. So what we believe in terms of pathophysiology is what I just showed. What we are actually practicing, this is a reverse engineer of what we're practicing. We are kind of like practicing under the assumption that risk factors should be there to basically cause the disease. Disease should cause symptoms, and symptoms should cause MI. That's wrong. The reality is that there is atherosclerosis that causes MI. There is not a one-to-one relationship between risk factors and atherosclerosis, meaning in two twin brothers with exactly same profile, one might have atherosclerosis, the other one might not. And there is so much more to it than just presence of one-to-one risk factor to atherosclerosis. And some people have symptoms and some people don't. So we can't rely on those things. So we can reverse engineer the MI. Why MI happened? Because of a plaque rupture. Why plaque rupture? Because it progressed. Why it progressed? Because it existed. So very simple. And there is a reason for its existence, but it's much more complicated to try to figure it out and guesstimate its existence or not. So we have these identifiable risk factors, genetic factor, environmental factor, inflammation, and X, which is probably 50,000 other factors that in 50 years from now, they're going to figure out and they're going to laugh at us, that you guys didn't know that. But what we can do with this framework is that we can actually start thinking about a personalized treatment based on detection of atherosclerosis, maybe intensifying the treatment based on presence of progression, and thinking about revascularization if we see plaque that is at the risk of rupture. And when we talk about progression, is not just a luminal progression, is a progression of features that gets the lesion more and more close to MI. So that's an increase in necrotic size, thin fibrous cap formation, and exposure of that to a shear stress that can cause a plaque rupture. So when we think about this, we need to redefine this whole concept of high-risk plaque, as Dr. Nagavi did that in 2003 with his from vulnerable plaque to vulnerable patient. What I'm trying to do here is to remind us that this is not a binary concept based on presence or absence, but it's actually quantification of some plaque features. It's a dynamic concept because our medical therapy changes it, the natural progression changes it, and it's a lesion level concept. And it's a marriage between the physiology and pathology at the lesion level. And what we can do in the near future is to marry these two concepts in order to have a better understanding of who benefits from aggressive medical therapy and who benefits from revascularization, which I'm just gonna fly through these slides that kind of like presence of plaque allows us to individualize our medical treatment, which I'm going to call it a personalized optimal medical therapy, as opposed to optimal medical therapy based on overall plaque and individual plaque features. And it can guide us to revascularize both for symptoms and for MI prevention. And we have tools that is combination of CT scans and AI. And this is an example of it from a Lucid company that can guide us towards the risk for symptoms and the risk for MI prevention. And I think to wrap it all together and bring it back at a population level, I think there are very interesting efforts that you can actually reduce the need for contrast in these images, and by AI, go to try to detect non-calcified plaque, plaque features, even physiology based on a non-con imaging in the next few years. So with that, I thank you and